Good evening, all, and welcome you all for the monthly ICU clinic organized by the ISCCM every month for the benefit of the critical care trainees. And for today's ICU clinic, which is diabetic emergencies, we have two senior examiners, Dr. Suresh Ramsubban and Dr. Kalavati ma'am. Dr. Suresh Ramsubban is not only a seasoned examiner, but also a prolific speaker, both at the national and the international forums. Dr. Suresh Ramsubban is the critical care in charge at Apollo Hospitals, Kolkata. He has numerous publications to his credit and served as an office bearer to ISCCM at various positions. We have also senior examiner, Dr. S. Kalavati, ma'am, who is a senior consultant in critical care medicine at SIMS Hospital, Chennai. She has over 30 years of experience in clinical practice, teaching, and research. To oversee this, we have a mentor, Dr. S. Kaladar, who was instrumental in case preparation for the two students. Dr. Kaladar is the head of the department at Yashoda Hospitals, Malakpet, Hyderabad. We have two students here who will be presenting these case scenarios. We have Dr. Devaki Kavyasri, who is a second year DRNB critical care medicine student at Apollo Hospitals, Jubilee Hills, Hyderabad. And we also have Dr. Vishwadeep Chakrabarti, who is an IDCCM trainee at Health City Hospital, Guwahati, Assam. So over to Kavyasri for the initial presentation on diabetic ketoacidosis.
Good evening, everyone. I'm Dr. Kavya. I'm going to present a case today. An old gentleman presented to the hospital who used to work as a software employee with the complaints of fever, shortness of breath, and generalized weakness since 2 days. Change the slides. Coming to present of interest, patient presented with fever since 2 days, intermittent, subsiding with the medication, and patient was also complaining of shortness of breath since 1 day, mostly on exertion, and was associated with generalized weakness and fatigue. And asking upon, he has complained of nausea and vomiting since 3 days, and he is also having constipation since 5 days. There is also history of polyuria and polydipsia since a month. For the same, he got his health checkup done 1 week back, and he found to have high blood sugars. And there is no history of cough, chest pain, cold, palpitations, abdominal pain, or loose stools. And he has no other comorbidities like hypertension, thyroid, coronary artery disease, chronic kidney disease, or any cerebrovascular accidents. And there is no surgical history prior, and no history of previous hospitalizations. And the past history goes like no comorbidities and no surgical history. Coming to personal history, he used to have a mixed diet, and he's a social drinker and not a smoker. And coming to family history, which was not significant. This was the history, sir. And my DDs from this would be like acute gastroenteritis, intra-abdominal infection, diabetic emergency is the possibility, and subacute intestinal obstruction in view of his symptoms. And on general examination, patient was moderately built and moderately nourished, and there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and pleural edema. On systemic examination on gastrointestinal system, there was no scars and sinuses noted. Abdomen was soft and non-tender. Bowel sounds were heard. On CBS examination, heart rate, H1, H2 were heard, and no murmurs heard. And on CNS examination, he was conscious, coherent, and oriented, with the pupils equally reacting to light. On respiratory system, bilateral air entry was present, and no added sounds were heard. On arrival, patient presented in ER with the above complaints, but he was conscious and oriented. He has complained of fatigue on exertion. Vitals goes like sinus tachycardia 126 per minute with the BP of 110 by 60 mmHg, and respiratory was with little tachypneic 26 per minute with saturation of 97% on room air, and he was felt febrile on arrival with a GRBS of 379 mg per dl. And we have done ABG also for him, which shows like 7.16, which was acidotic with the carbon dioxide of 12.8 and PO2s of 112, with electrolytes goes like 141 of sodium, 3.4 of potassium, and chlorides were 119. Calcium was little higher side, 1.49. Lactates of on baseline of 1.9, anion gap of 17.6, which was higher, and bicarb is very low, 9.4, with a base excess of -22. Initial labs we have done meanwhile managing the patient. CBC goes like 12.8 and with a hematocrit of 37, and TLC count were little higher, 14,000, with a normal platelet count. Creatinine was 0.8. CUA shown glucose 3 plus and ketones 3 plus, and pus cells of 8 to 10. Serum electrolytes also within the same range of ABG values. And CRP was little higher, slightly higher, 18.7. And screening today echo we have done it, which was normal and unremarkable. Patient was managed initially with a fluid bolus of 1 liter crystalloids of 0.9% normal saline, and started on insulin infusion 7 ml per hour with suspicious of diabetic emergency, with the regular monitoring Harley GRBS and maintenance fluid. We have started 0.45 NS at 150 ml per hour and shifted to ICU for further management and regular follow-up. And on day 2, patient continued to have sugars in higher range of 250 to 300. So insulin infusion was continued at 7 ml per hour. IV fluids continued at 100 ml per hour and added for each bottle with 40 MEQ injection KCl, because potassium was little lower side. ABG was being done 8th hourly, and serum electrolytes checked twice daily with Harley GRBS monitoring. And second day it was all good. Urine output was also adequate. No fever spikes. Frequency was reduced, and there was no vomitings further, and bowels not opened yet. And ABG goes like little correction in anion gap from 17 to 14.6, with bicarb of little correction from 9 to 12, with base excess from 22 to -18, and acidosis mild correction 7.22. Electrolytes were in the hypokalemia was there, with a little correction in the chlorides also. There is a decrease in the calcium also 1.37, with lactates getting corrected to 1.7. And evening ABG was also a bit of improvement, with the continuation of scale and with Harley GRPS and potassium correction along with the maintenance fluids. Lactates were improving 1.2. Anion gap was also getting corrected, with bicarbs increasing on their own to 14.7, with base excess also getting corrected -8.9. On the labs on the day 2 were like 11.2 CBC and a little correction in the TLC count also 12.5 from 40, creatine 0.7, and electrolytes were in the normal range with the mild hypokalemia side. CRP was little increased, and HbA1c we have done, which was showing 10.1 for him. On day 3, patient still having sugars in the higher range, ranging between 250 to 350. So continued an insulin infusion and started long-acting subcutaneous insulin, and IV fluids continued to be at the same range, 100 ml per hour, and added with the same potassium correction. ABG was done same 8th hourly, and serum electrolytes twice daily. And there was one fever spike started on day 3, 100.8 of Tmax. No vomitings further, and bowels not opened yet. And patient, but bowel sounds were heard, so started on soft diet with the oral correction of potassium also, along with the IV correction. Syrup Dufolac was also added for him. And in the next day, on day 3, ABGs were in the improving trend only, with bicarb 16 in the morning, with base excess minus 7.4. Hypokalemia was still persisting. So started on a syrup Quatlor also for him. And in the evening potassium was still low, 2.8 in the evening. Lactates getting corrected. Anion gap is slightly in the higher side. Bicarbs of 19.6 and base excess was minus 7.2, but acidosis got corrected and labs were in the improving trend only. Electrolytes 3.2 potassium hypokalemia side, and urine cultures and blood cultures were came from uh, 48 cultures, final cultures, which were negative. And on day 4, patient has persistently high sugars between 200 to 300 on Harley GRBS. So, but stopped on insulin scale while maintaining on subcutaneous insulin with the intermediate acting Novomix 50 uh, subcutaneous insulin. Patient continued to have hypokalemia in spite of IV fluid maintenance and syrup formulation. Sensorium was overall good and good urine output, tolerating feeds and bowel opened once. Uh, and patient got shifted to WhatsApp for further care and follow-up. And labs were in the improving trend only, sir, on day 4. With the lactates of 1, anion gap 7.6, bicarbs also above 20 it was, and there is no acidosis. Urine ketones we have sent on day 4, which came as a 1 plus. Compared to day 1, it was 3 plus. And CRP is more or less in the same range, but persisting hypokalemia was continued
Fair
with
enough,
the
fair enough.
hypokalemia corrections with the IV and
Dr. Devgi,
yes,
can
sir.
you hear me?
Yes, sir. Yes, sir.
All right, go back to the first slide. This is fair enough. I will tell you what all the problems are. Dr. Kalavati ma'am, you can also join asking. I think go back to the first slide and then we'll start asking you questions. It's fair enough that this is straightforward DKA.
Yes.
So the first question, go back to the first slide.
This was the
first slide.
yes, sir.
Yeah. So how do you explain shortness of breath in a patient with diabetic ketoacidosis?
Yeah, exactly. That is my question also.
Sir, on exertion, he has complained of it, sir, because he was a working gentleman on software going person. He had all the symptoms since 1 month, but he had fever spikes with the mild lethargy was there for the patient. He has complained of that, and he has shortness of breath while going to work also because of an exertion.
No. Madam, very specific, simple question. Madam, very simple question. What is the cause of the shortness of breath? It's very obvious.
Because acidotic, on arrival, we found acidotic.
So there are lung causes and there are non.
Yes.
So what are the non-lung causes of? Yeah, obviously acidosis, isn't it? So
Yes,
you must have been correct. So the cause of shortness of breath is. Are you able to hear me?
Yes, sir.
Are you
Yes,
able
sir.
to hear me?
Yes, sir.
Is my voice clear or
Yes,
Yes,
yes.
sir, clear.
breaking up?
Clear, sir.
Yeah. Your history says that his health checkup was done.
So what kind of respiration do we call it in DKA?
Small breathing, sir. Fast breathing. Acidotic breathing.
When you have a breathlessness because of acidosis, what is the kind of respiration that you...
Shallow breathing, sir. Kusumal breathing.
Okay. Yes, ma'am.
Yeah. Your history says that he had his health checkup 1 week back.
Yes, yes, ma'am.
And high sugars.
Fair enough. That's called Kusumal's breathing. It's Kusumal's respiration. All right. So what kind of a smell would you expect when you...
Fruity odor, sir. Because of acetone breath, sir. Acetone breath. Fruity odor with the
Yes, ma'am.
Acetone breathing.
Dr. Kalavati, ma'am?
Yeah. Um,
You were saying something.
yeah. He had his health check 1 week back.
Yes,
Was he
ma'am.
on any treatment? Because high sugars were found. So did he
Yes.
start any treatment on
He
for
didn't
that?
start, ma'am. He didn't start, ma'am.
Okay. Yeah.
He didn't get it evaluated, ma'am.
So based on this history, you said, next slide. Show me your next slide. Next slide. Yeah. So why did you say acute gastroenteritis? On what basis?
Sir, he has a fever spikes, sir, and also with the history of vomitings, nausea, and constipation also. Uh, Considering vomitings and nausea, acute gastroenteritis can be one of the possibilities, sir, with maybe because of food poisoning and all. Uh,
But then you said there was constipation, isn't it?
yes, ma'am.
How does it fit into the diagnosis?
Uh, maybe because of vomiting and all, maybe he was uh, not having his meals properly. Maybe that can be the possibility of constipation along with the vomitings and nausea, ma'am.
So the So when you form a differential diagnosis for a patient who has got fever, shortness of breath, and has got non-specific symptoms, it is very difficult to form a differential diagnosis of a diabetic emergency or a DKA or anything unless you have a subacute intestinal obstruction and with a physical finding which is absolutely normal. So all these are the nausea, vomiting are what we call as constitutional symptoms or non-specific symptoms, especially if they are not associated with anything. So this is going to be a little tricky to form a differential diagnosis. So why did you say diabetic emergency in this differential diagnosis?
Sir, by the time we didn't, he was lethargic, sir, but not that drowsy also. So uh, we can't rule out unless we tested him with the laboratory testing, sir, between DK or HHS. That's why I kept diabetic emergency.
Do you think DKA per se could have caused?
Go back to the first. Go back to the first slide.
Yes,
So
sir.
he's got. So the only thing that is pointing towards you for a diabetic emergency is the polyuria and polydipsia and a known high blood sugar. A young man probably is getting type 1 diabetes. Okay.
Yes.
So what is the diagnostic criteria for a DKA?
So diagnostic criteria would be after investigating with the basic blood gases, sir, with the acidosis.
Yeah, go on.
Yeah.
How much?
Acidosis of less than 7.3, sir. Less than 7.3. Ketonuria more than 2 plus, sir, and anion gap of with high anion gaps.
How much? Greater
More than 12, sir. More than 12.
So you have to have three criteria. Number one is, so you have to have three criteria for diabetic ketoacidosis. One is the sugar.
High sugars. More than
How
250.
much should the sugar be?
More than 250, sir.
More than 2.
Yes.
All right. So second is acidosis. What should the pH be?
Less than 7.3.
So what should the bicarb be?
Bicarb less than 15, sir.
Less than?
15, 1.5.
Where did you come from that number? Are you
Sir,
sure?
yes, sir.
I have always been taught 18.
In this JVDS and ADA, it was mentioned.
So you say 15. I don't agree on that. All right. So what about anion gap?
Anion gap, high anion gap, sir. More than 12. 12.
More
10
than?
to 12. More than 12.
More than. And the third is?
Ketonuria.
So hyperglycemia, metabolic acidosis, ketosis.
Ketosis.
What about blood? Only in the urine or in the blood?
Plasma and urine both. We can.
Which is more reliable?
Okay. So
Plasma
what
is
is
more
the urine
reliable, but it
ketone?
is
When you do a urine ketone,
urine
that's
ketone.
fair enough. You can have any one. It's all.
Yes.
It's all right. It's all right. You're right. It's either urine ketone or blood ketone. That's
Blood
all right. You're right. So my question to you is, how do you, when you do a urine ketone test with a dipstick,
Yes, sir.
what is it? What is the method called as?
Electro. Nitroprusside.
Yeah, nitrogen.
Nitroprusside.
What kind of, so what are the three kinds of ketones that you know of?
Acetone, acetoacetate, and hydroxybutyrate, beta hydroxybutyrate, sir.
So
Which one
urine
does
test
the,
detects what?
Sir, urine will have only acetoacetate, ma'am, and acetone will get eliminated through respiratory system, and blood have beta hydroxybutyrate in addition.
so when you, that's why blood is probably this thing.
Yes.
So you did a lot of ABGs. Do you really need to do so many ABGs? You wasted the patient's
Actually,
money a lot.
yes, sir. Actually, we have restrained doing ABG, sir, but daily,
But
twice
do you
daily.
need an ABG? Do you need an
Uh,
ABG?
till there
Do you
is
need an
a
arterial blood gas?
ABG or BBG is also fine, sir.
Absolutely. So a venous blood gas is good. All right.
Yes.
Next slide. Show me your next slide. Next slide. Next. Next. Already. So please interpret the ABG again.
Yes, sir.
Go back.
This one, sir.
Yeah.
Yeah.
So there was acidosis as per the definition less than 7.3 and bicarb of only 9.4, sir, and anion gap of more than 12, that is 17.6 in this ABG, sir.
How do you?
So fitting into the diagnostic
Okay.
criteria.
No, no.
Acidosis,
Okay.
it,
So is that all?
uh,
So no, no.
there
Is it
is a
only a high anion gap metabolic acid? What is the delta delta gap here?
uh,
So your bicarb has gone from
bicarb has
24 to 9, which is almost 15, while your anion gap has only gone from 10 to 17. Where is the remaining 8?
12 was the we consider.
So even worse, na, anion gap has only gone up by 5. Bicarb has gone down by 15. So where is the remaining acid?
Uh,
If you're doing a DRNB in critical
dehydration.
care and you don't interpret the ABG to a high anion gap or non-anion gap, you don't proceed any further, and your exam and your career is over. Isn't it?
Yes.
So is this a, how do you explain a chloride of 119?
Chlorinias
So there is a
because
non-anion gap metabolic acidosis, yes or no?
sir, this sir.
Is there a normal anion gap metabolic acidosis also or not? Please do the delta delta gap and let us know. You can use a calculator. You have a computer in front of you.
One 1.8 more than 1.
So what does that tell you?
1 means pure gap. No and no non anion gap acidosis.
Why?
Pure
What is
anion gap acidosis.
Hmm?
If delta is in between 1 to 2, it is pure anion gap acidosis, sir. High anion
Okay.
gap.
So your delta in this situation was how much you said?
1.8, sir.
Really?
Yes,
Okay.
17.6 by 9.
17.6, no, Baba. 17.6 minus 12. Delta. It is not 17, it is the difference between the anion gap, which is expected 10 to 12 to 17.6, which is you are wanting to say, and the difference between bicarb 24 to 9. 24
Yes,
to
sir.
9 is
Less than
15. Say,
0.3, less than 1.
So then what it tells you?
Both high and non-anion gap.
Thank you very much.
Yes.
If you prepare
Yeah.
a slide and if you don't do this, then it's really sad. All of you, please, whoever is listening, I think it's very important that do not stop. It is because what has happened is that in an exam also you guys make the same mistake, that you just assume that this is a DKA case, I don't need to worry about it. Okay, please calculate the metabolic parameters, delta, and now tell me the respiratory competency. Is there a respiratory alkalosis also? Please do the ABC the full
Yes, sir.
way. There is nothing called a halfway here. Okay, so I'm okay in saying this person also has an aspirin toxicity. That's my differential diagnosis for you. So, all right, so it can go anyway. So, you please calculate it. It doesn't make sense to me for somebody who has come in with a hyperchloremia. So, this ABG, either you have not calibrated it properly or this was done after saline was being infused. This is not the first ABG or the first VBG.
This was.
Or the patient, because of the what other reasons can you have so much of with a high chloride of 141? Sorry, 141. Chloride is 119. Is some of a bicarb of 9. Chloride of 119 is why is the patient have is an issue, isn't it?
Yeah.
So maybe something is wrong here. So please do the calculation. My only suggestion is do not assume it is DKA only. You don't know in the exam what I'm going to give you, isn't it? So it might be something twisted. So do just please always, when you calculate an anion gap, get into the habit of doing the delta gap. And it is so obvious to see when you know this that the bicarb has fallen so much, but the anion gap hasn't increased that much. So it is obvious that there is some other acidosis happening here. You don't even have to do a ratio to know what is happening. Okay. All right. So based on this, so what do you think is with this potassium 3.4?
Yes, sir.
Would you start IV insulin on this patient?
We have to start maintenance fluids with the
No.
potassium correction, sir, till more than 3.5 it is.
What is the cutoff potassium?
If it is less than 3.4, we have to correct potassium first, ma'am. Cutoff is 3.4.
3.3.
3.3.
Yeah.
All right. So in this kind of thing, so your fluid, the guy was tachycardic and hypotensive or normotensive. What was it? Tachycardic only?
Yes, sir.
So
Tachycardia.
how much amount of fluid do you want to give this guy?
So 1 liter, minimum of 1 liter need to be given, sir, to
Over
see
how long?
to check the response over 1 hour.
Okay.
Then following by 1 liter again in the next 2 hours, sir. Like that.
Can you go to the clinical picture? How he presented? Yeah, he's tachycardic. And do you think the respiratory rate matches the history and
Yes, ma'am. It is
his
technique
FBG?
only.
How do we explain the rate?
More than more than 22, we consider it as tachypnea only, ma'am. 26 it was.
Unless they are taking huge tidal volumes, we don't know. Okay. Yeah.
All right. So what is the sodium in this patient?
130, 141, sir. Lab it
140.
was 142.
So what is the corrected sodium?
Corrected sodium was 41.
Do you need
How
to
do
do
you
a corrected sodium?
Yes, sir. Yes, ma'am.
Why?
Maybe because of osmotic diuresis, because of high sugars, there will be osmotic diuresis, loss of electrolytes in the urine, ma'am. So,
The sodium here, would it be the
will be
actual sodium?
no,
sodium would
ma'am,
be higher than 141 or lower than 141?
higher than 141.
Very good. By how much? And why? What's the formula that you've been taught? So for every 100 milligram above normal, you either used to use 1.6.
Sugars.
Nowadays we
Yes,
use
sir.
2.
So,
Isn't it? The sugar here is
based on GRBS, if above 100,
yeah.
if GRBS is 400, then 400 minus 100, that is 3, sir. 3 into 1.6.
Nowadays we use
Is the
2.
correction factor, sir.
So 147. So what is the after your initial resuscitation?
141 plus
2 into nowadays 2.
4.8.
It's no longer 1.6. It's 2
Okay,
nowadays.
sir.
Easier for you to
So
remember.
147. Yes.
So your fluid that you gave him, was it right?
Yes, sir. 0.45 only we have given, sir.
All right. And when do you, so you started initially him on 1 liter
With
over 1 hour?
yes. We started with initially 1.9% only. But after the labs and everything came, we started on 0.45.
Okay. With potassium or without potassium?
With potassium, sir, because borderline 3.4 potassium, we have started with
How
the
much potassium?
40 MEQ, sir, within each 500
Okay.
ml NS, 0.45
Okay.
NS.
So why did you have so much problem with hypokalemia? What is the average potassium deficit that most of the patient have?
Potassium deficit be 100.
The average would be about 300 to 600 milliequivalents.
300 milliequivalents.
Because most of the potassium is intracellular. Everything goes in with the intracellular dehydration. So I use 3.5 as a cutoff, which is what up to date will also tell you about using cutoff. So we will not start IV with the fluids. We'll correct the potassium and get it above 3.5 before most of us would start insulin. 3.4 to 3.5, whatever is what is called as lower limit of normal. So 3.4 in most labs is normal. Some labs will use it 3.3. General teaching is that it should be below the lower limit of normal. But what most of the teaching nowadays is that even if it is on the lower limit of normal of your lab, which can be 3.4 or 3.5, take 3.5 as a cutoff and first give 20 milliequivalent. What rate of potassium do you need to give before you start?
Like not more than 20 milliequivalents per hour, sir.
Correct. So you need to give that 20 milliequivalent to 30 milliequivalent per hour you can go. You need to give that before you start the insulin. Otherwise, you will never be able to keep up. Insulin pushes the potassium in and it will cause further hypokalemia. And the deficit will continue to increase and increase, and you'll never be able to catch up because you're measuring this thing. And that's why you ended up having this patient stay for such a long time. All right. So
Yes.
that is one of the most important thing is that if you are once you get above 3.5, then each bottle should at least have 20 milliequivalent per liter of IV fluids, and the fluid should be 0.45. Next slide, when you come to, is the question is, when do you stop insulin. Your lactate anion gap is 14.6, 11.6. So would you stop at this point in time at insulin, IV insulin at anion at ABG at 5 p.m.?
No, sir. We didn't stop it, sir.
Why not?
Evening.
If he's eating well, why not?
Because still there is a my acidosis was persisting, sir, still in this ABG2.
But again, it's still hyperchloremic acidosis. It's not anion gap acidosis now. That's exactly the mistake you're making.
Sir,
And you're
hyperchloremic.
still continuing IV insulin with a potassium of 3. You're unnecessarily leading to another day in the ICU. So what is the cutoff? What is the indication
In
for
insulin
switching
rate,
from?
we can switch from 0.1 to 0.05
Yeah,
and
but at
shouldn't be
what
considered.
point? What point do you stop? You decide to stop insulin and then give an overlap. Do you think of an
Give,
overlap?
but this evening also they didn't overlap with the subcutaneous insulin, ma'am. Next day only after there was no acidosis on day 3 they overlapped, ma'am.
But you're not understanding. It is not a high anion gap acidosis anymore.
Yes, sir. Insulin rate was reduced, ma'am, by this evening, and by the morning stopped insulin because everything
Okay,
got corrected except
let me
the
ask you once again. How do you decide to stop insulin infusion? Correction of what?
like acidosis based on anion gap we should stop.
Or if you have a blood test, what blood test would you send?
Like beta hydroxybutyrate we can send, sir.
What is the value?
Value of less than 6. If it is less than 6, we can stop it.
All right. All right. So the only reason I would have continued to agree with you is that the bicarb is still less than 18, which is what is one of the criteria. And since the anion gap is less than 12, and I have a feeling this is hyperchloremic acidosis, I would do. So do you know of any study which has compared normal saline versus balanced salt solution for resuscitation of DKA?
I don't know any named study, sir. There was a meta-analysis in 2011.
Right.
They have it in inference that balanced crystalloids will be better than the 0.9 or isotonic fluids like NS, sir.
So now if you were to go back on this patient of yours,
Yes.
what crystalloid did you choose? He had a chloride of 119 to start off with, and he still has a high normal anion gap metabolic acidosis. So what was your crystalloid here? So SALT TD and SMART study were the two studies of balanced salt solutions which looked at the thing. The meta-analysis happened after that. There is no significant change in outcome, but definitely if you have a hyperchloremia like this, I would have preferred to start a Ringer's lactate in this situation. Right? Or a balance, whatever is your favorite company which provides you with balanced salt solution.
The patient has been tachypneic, and the bicarb is low. Do you think of giving bicarb infusion?
No, ma'am.
Why?
First, we have to see the response with the fluids, ma'am. And we consider bicarb only when there is a severe metabolic acidosis of pH less than 6.9, ma'am.
Okay.
When do you replace phosphate?
Phosphate also after fluid correction. Hypophosphatemia is one of the risks, ma'am, but no need to correct as such. We can.
All right. So transition from subcutaneous to IV to subcutaneous. So what is the criteria once again? 3 things, like the way you define DK, tell me, then we will stop and we'll go to the next case.
During transition, first IV insulin should be continued at least 2 to 3 hours of subcutaneous insulin dose given, sir. Uh, because it is a short acting insulin, whatever we are giving in IV, it lasts at least 2 to 3 hours. By the time
Is it true even if I
subcutaneous
use
kicks
an
in, sir.
ultra short acting insulin like nowadays most of the insulin humologs and all those things are ultra short acting. Even in that it's valid. 4 hours or 1 hour, or is it only
We
for?
but we regularly use short acting only, sir. Actrapid.
But you're still not getting my question. I think all of you guys should really need to answer this is that what is the criteria for stopping IV insulin in DKA? Number one, you said is resolution of ketoacidosis. That is
Yes,
anion
sir.
gap bicarb more than 18, anion gap more less than 12, pH more than 7.3, and no
Yes.
detectable uric beta hydroxybutyrate or urine ketones. Stable blood glucose, that is less than 200, is what we want. And then patient is able to tolerate an oral diet. This is the criteria to stop. How do you stop it? You use a basal bolus insulin nowadays. So you will give a long acting detamir point, or in a person like this who's probably a type 1 diabetic, a zero point 0.5 to zero point 0.6 unit of this thing, followed by a mealtime insulin, followed by a sub SSI. So then this has to be depending on whether you use the mealtime as an ultra short acting or a short acting. This has, and the bolus you have to stop anywhere from 1 to 4 hours, depending on, and the what is it, uh, do it simultaneously. That's what you need to understand, the transition protocol. So these are two words that you need to know. What is the criteria for stopping and what is the transition protocol that you follow in your ICU? These are the words that we want to hear so that we can pass you without listening to your answer. Ma'am, anything more on this or should we move on? Because we have taken a lot of time on this.
Yeah, I think we can move on. There is one thing regarding the trigger. What do you think was the trigger for him?
Um, trigger. We have suspected UTI, ma'am, actually, but
What,
cultures, ma'am,
based on?
because pus cells were also there. Uh,
Yeah, but do you think it's common in men? Do you think he's a likely candidate for UTI?
no, ma'am.
But can you completely rule out?
With cultures we can, ma'am, but fevers also started on the day 3, day 4.
So with
Yeah.
abdominal pain, did you look
Maybe.
for, or nausea, vomiting, did you look for amylase, lipase, or pancreatitis as a precipitant here?
Yes, sir, but but there
Yeah,
is no history of abdominal pain or anything, sir.
your history says no. There is a.
No
Can you go to
abdominal.
the first one? No. Okay.
So can you have an
Yeah.
increased amylase,
Okay.
lipase without pancreatitis in DK?
Uh, in DK, like no, there are conditions like salivary gland also releases amylase. So
Very good. What about lipase?
lipase, uh,
Anyway,
in
I think when we
insulin
talk about
deficiency.
pancreatitis, whenever there's a pancreatitis lecture, we will talk about how to diagnose pancreatitis in DKA, but not today. But yes, the amylase lipase can be elevated without any reason. The only other thing in the diagnostic criteria before we forget and before we move on is in the presence of newer medication like the SGLT2 inhibitors, you can have a euglycemic ketoacidosis. So the criteria for DKA with a blood sugar more than 250 may not be valid at all times. Please remember that. That
Yeah.
is the only thing. Otherwise, diagnostic criteria, fluids, potassium, when to start, why potassium, correction of hyponatremia, correct, knowing, understanding that how to correct for the hyponatremia and this thing is what is important for you guys. Okay? And all this exam in IDCCM exam, the exam will stop if you don't interpret the ABG.
Thank you, sir. I think can we move on to the next case, sir?
Yeah.
Shortage.
Go on.
Should I start?
Yeah,
Yeah,
please.
go on.
My case, he was a 68-year-old male patient, presented with chief complaints of high-grade fever since past 4 days. He had polyuria, dysuria, lethargy, decreased appetite, and reduced oral intake since past 3 days. And he also developed altered sensorium since past 12 hours. There was no history of vomiting or abdominal pain. There was a gradual onset of drowsiness. The patient is a known case of type 2 DM since past 15 years. He was on irregular oral hypoglycemic agents, and he was non-compliant with both medication and diet. There was no history of recent steroid or thiazide use. There was no history of insulin use either. The DDs which I have come across from this present scenario are diabetic ketoacidosis, hyperglycemic hyperosmolar state, sepsis with hyperglycemia, a stroke or a CNS event, dyslipidemia, uremic or septic NCAF. These are the initial.
Just go back to the first slide.
Yeah.
Sorry, just
Yeah.
go back to the first. The encephalopathy and hyperglycemia. High-grade fever, decreased appetite, and low GCS. Why do you say stroke?
Sir, actually, the patient, I'm just
Okay.
to rule out one of the
Okay,
things to
this
rule
is
out.
before
Patient
the
is
examination. Okay. So
yes, yes.
encephalopathy, you got an altered mental status. You're giving me a differential diagnosis of altered mental status. All the differentials, isn't it?
Yes, sir.
Okay. All right.
Why did you give a history of a proactive history of a steroid or a thiazide use?
Ma'am, both these drugs can precipitate hyperglycemia, and it is one of the precipitating factors of the hyperglycemic hyperosmolar
What was the
states.
sugar on this? Go back on the history. Go back.
Sugar is
So
not.
you right now that you don't have a sugar, isn't it? So
No,
right now
sir,
you
no.
have somebody with fever and altered polyuria and suggestive of definitely some osmotic state, and then you have a alternate. Fair enough. Okay, fair enough. Good.
Yes.
Very good. Next. Next.
So on general examination, the pulse rate was 116 per minute. The blood pressure was 98/66. Temperature was a little bit on the higher side, 101.4 degree F. The respiratory rate was 24 per minute. Saturation was 96% on room air. The patient's general appearance was the patient was drowsy, with dry mucosa, sunken eyes, poor skin turgor. There was no pallor, cyanosis, icterus, or pedal edema. Onto the systemic examination. On auscultation, the air entry was equal on both sides. It was clear. The breathing was normal in pattern. CVS S1, S2 was present. No murmurs or added sound. There was tachycardia. Abdomen was soft. It was non-tender. Bowel sounds were present. On CNS examination, GCS was E2, V3, M5, though it was fluctuating sometimes between 10 to 12. Both pupils were equal in size and reacting briskly to light. There was no focal neurological deficit. The extremities were warm. Peripheral pulses were palpable. The initial lab reports. Initially, the bedside capillary blood glucose was beyond the measurable range of the glucometer. It was showing high. So a venous sample was sent for the lab confirmation, which showed marked hyperglycemia, 820 milligram deciliter. Sodium came to be 142. Potassium was 3.4. Magnesium was 1.6. Phosphates 1.8. Burn was 58. Create 2.2. Urine ketones were negative by dipstick method. Serum ketones were less than 0.4 millimole per liter. HbA1c was 11.2. The ABG findings: pH was 7.38, bicarb 26, lactate 2.2, chloride 106, sodium 150, potassium 3.6. The serum osmolarity was 350 millimole per kg. The TLC was on the higher side, 16,500, CRP 120, PCT 3.2. Urinary reports. The color was yellow, cloudy. Specific gravity was 1.030. pH was 6.5. Protein trace. Glucose was present. Ketones were negative. Pus cells 20 per HPF. Chest X-ray was done. It showed clear lung fills with no evidence of any cardiopulmonary abnormality. The ECG, it was normal sinus rhythm with no acute ischemic changes. CT brain was normal, steady for age, no acute intracranial lesion. USG was done, whole abdomen. It revealed mild diffuse bladder wall thickening. There was no structural abnormality or obstruction. Now in this case, according to the ADA 2024 guidelines, these diagnostic criteria were achieved. Plasma glucose here was more than 600. The effective osmolarity was more than 300 milliosmol per kg. The pH was more than 7.3. Bicarb more than 18. There were minimal or absent ketones. Anion gap is normal or slightly elevated. After all this, my initial the diagnosis which I've come up to is hyperosmolar hyperglycemic state precipitated by a UTI and in a known type 2 diabetic elderly male.
So
here is the ice. Yes, sir.
yeah. How would you proceed?
Should I continue?
Yeah, continue.
Okay. So this is the ICU course timeline on day 1. Initially, the patient had hypotension, which got resolved on the same day once fluids were started. There were febrile episodes. Patient was drowsy and confused. Fluid resuscitation was started with 0.9% NS. IV insulin was started after initial fluids and after seeing the potassium values. The ABG showed mild hypernatremia. pH was more than 7.3, bicarbonate more than 15. There was mild hypernatremia. Empirical IV antibiotics were started for UTI. Urine and blood cultures were sent. On day 2, the patient's sensorium was improving. The close monitoring of vitals, urine output, blood glucose was continued. Sodium levels came down slowly to the normal range. Infective markers level were high. Trending down was expected with the continuation of therapy. On day 3, the patient was shifted from IV insulin to subcutaneous insulin. The urine culture reports were now available. De-escalation of antibiotics were done. Supportive therapy, fluids, and insulin were continued. Effective osmolarity levels were coming down. Monitoring of urine output, renal function, and electrolytes was continued.
Sorry to interrupt, Dr. Vishwadeep. Your voice is too low. Can you talk a little louder, please?
Sir, is it okay now?
Yeah, it's all right now.
Okay, sir. So patient was now shifted to subcutaneous insulin on day 3 from IV insulin. The urine culture reports were now available. De-escalation of antibiotics was done. Supportive therapy, fluids, and insulin were continued. Effective osmolarity levels were coming down. Monitoring of urine output, renal function, and electrolytes was continued. TLC, CRP, PCT levels were coming down. On day 4, patient was stable, afebrile, sensorium improved. Blood glucose targets were achieved gradually. Effective osmolarity levels trending down. They were normalized now, and patient was shifted out of ICU with an insulin regimen. Patient was later educated on diabetes management and follow-up was planned. So the take-home message would be that early recognition is key, identifying and treating the precipitants, careful fluid and electrolyte management, following insulin therapy principles, frequent neurological, renal, and hemodynamic monitoring, early involvement of critical care, endocrinology, and infectious disease teams, proper stepwise management allows for rapid clinical improvement.
So what is the insulin therapy principle you followed here?
Ma'am, we have to monitor the blood sugar hourly initially. So after first once we have started with the 0.9% NS, ma'am, actually I had as a diagnosis I had understood it to be hyperosmolar hyperglycemic state, in which case more than insulin, the correction of the fluid status was more important. So ma'am, but still, as there is a relative insulin deficiency in this state, so insulin, there was insulin to prevent ketoacidosis, but not for hyperglycemia. So for that, we had to give insulin. So after the initial perfusion, after first giving the IV fluids, then I had seen the potassium levels, and in this case my potassium came to be 3.4. So before starting that, I had given around 20 to 40 milliequivalent of KCl, and
Yeah.
lower rate than DK at 0.05 units per kg per hour rate, ma'am. And initially I had monitored it hourly till I had gotten the required target of reduction of blood glucose level of 50 to 75 milligram per hour.
Okay. So which comes first? Your do you start fluid and insulin simultaneously, or what do you address
Hello.
first? Yeah. Can you hear me? Can you hear me? Are you able to hear me, Dr. Vishwadeep?
Hello, ma'am. Am I audible?
Are you able to hear me?
Yes, ma'am. I'm able to hear you.
Yeah.
Sorry for the lag.
No. Which
I'll
would
share the
you?
screen again.
Yeah, which would you start first? So you said.
Hello, ma'am. Can you hear me, ma'am?
Yeah, I can hear you.
Hello.
Can you hear me? Can you hear me?
I think Dr. Vishwadeep, your internet is very unstable.
Okay, you're able to hear me, Dr. Bhavani Prasad?
Yes, ma'am. Your voice is clear to me.
Okay,
I think there's a problem with Dr. Vishwadeep's internet.
Okay. Yeah.
All right. Can we see your ABG slide again?
Yes, sir. Sir.
Yeah, Dr. Suresh, go on.
Yeah, please interpret the ABG.
Yes, sir. So the pH values are in the normal range. The bicarbonate is normal. Lactate is little bit on the higher side, borderline. The chlorides are normal again. Sodium is little bit on the higher side, sir. Potassium levels are normal.
So there is no acid.
Sir, here we don't. No acidosis, sir. There's no metabolic acidosis here.
Okay. Is there a metabolic alkalosis here?
No, sir. They're normal. The pH is normal.
So you're saying 22 to 26, you're taking upper limit of normal. Then why? So why is the lactate high then? Why is it not reflecting?
Sir, the lactate may be high due to the extensive dehydration and. and there might be some problem with the perfusion, tissue perfusion. That may be.
So what is the anion gap here? Or should you
Sir,
not
the
do it
anion
at all?
gap here? No, sir. It is required. It is required to rule out decay.
So what is the anion gap here?
So the anion gap will be around 1. Sir, around 2024. It is little bit on the higher side.
Little bit or a lot?
Lot on the. It is
Lot on the
high
higher side. So now interpret the ABG. So you have a normal pH, slightly elevated bicarb, slightly elevated sodium, slightly elevated chloride, a high anion gap. So is there, so whenever you see a high, so again, please get into the habit of, whenever you interpret an anion ABG, do everything is also okay. You got to look at the high anion, is there a high anion gap or not? So to me, I'm looking at this fact is that the patient is significantly dehydrated. There's a significant contraction alkalosis, hypernatremia is
Yes,
there.
sir.
So there is a mixed disorder that is present here. And that's why somehow because of the contraction alkalosis, your pH is corrected. All right. The other thing is osmolarity. How do you calculate the serum osmolarity?
Sir, we calculate the serum osmolarity by multiplying 2 into the sodium level. Then, sir, we add it to glucose by divided by 18 and Bun divided by 2.8, sir.
So this is a measured osmolarity or a calculated osmolarity that you have presented
Sir,
here?
this is the calculated serum osmolarity.
So for the diagnostic criteria of hyperosmolar coma
Yeah,
or
for
hyperosmolar,
that, sir. Yes, sir. For that, we need the effective to calculate the effective osmolarity, sir.
Okay. So which is an ineffective osmol?
Urea is a ineffective osmol, sir.
Very.
It has it freely passes through the membranes without having any effect on the osmotic gradients.
What is the expected fluid deficit in HHS with this kind of an osmolarity?
Sir, the expected deficit would be on the range of around 6 to 8 liters, sir, or a bit more.
On the lower side, yeah.
So again, fluids, how much did you give initially?
Initially, sir, actually, the plan was to initially for the first hour we had given NS of 1 liter. Then, so the plan was to correct half of the deficit.
Again, yes, same thing. Now, what is the calculated sodium here with the sugar? Why would you use 150? But all right. So again, same thing. Again, please look at the fact that one of the biggest problems in treating hyperglycemic or diabetic emergencies is the fact that when you have a 106 chloride, when you have a sodium of 150, NS is probably not the great amount of fluid. Okay, so crystalloid, the idea is crystalloid, so please stick to the right fluid for this. Otherwise, you'll never be able to correct it fast enough.
That is true, sir.
So the idea is,
sir, actually by the time.
Go ahead.
Yes, sir. Sir, but actually, by the time the sodium levels were evaluated, the initial recitation, the first hourly it was done. Then, in the second hour, we switched to half NS, sir.
Yeah, but still you need to calculate the sodium because it is a hyperglycemic.
Yes.
Yeah.
Yes, ma'am. Yes, ma'am.
And how do you replace fluids? See, the deficit, what did you say the deficit is, actual deficit in hyperglycemic
yes, ma'am.
State?
Ma'am, it is around 6 to 8 liters. Ma'am, the plan was to correct half of the deficit in the first 12 hours and the next half on the next 24 hours. That was the plan, ma'am. And my target was to... Sir,
What happens if you correct it too rapidly?
sir, if we are overzealous in correcting the fluid deficit,
Yeah.
it might lead to complications like cerebral edema, sir.
Right.
See, one of your lab values gives a clue on why we might be little careful about very rapid infusion of fluids.
Alrighty. So these are actually straightforward questions in the exams, and we expect you to ask. I think the message that if you're hypotensive, you give fluid as far in both DKA and hyperglycemia. You give the crystalloid as soon as possible, as fast as possible. If not, the deficit is you need to give 15 to 20 ml per kilogram in the first hour, and then continue that to a maximum of 50 ml per kilogram in the first 4 hours. This is the general fluid deficits that you will have to correct in DKA, and probably slightly higher. Very easily, you can go up to 50 ml per kilogram over the first 4 hours in your in all your hyperglycemic emergencies. All right, so that's how, if you are hypotensive, then you give the normal saline and rapidly in 10 minutes, or crystalloid, whatever RL, in 10 minutes to 15 minutes. If some BP is okay, like the first case that you saw, you can give it in 1 hour, like that, up till you see a resolution of hypovolemia, and then based on the sodium at either 2 hours, or generally we do it at 4 hours, we reassess the sodium and then do the remaining change of fluids to half normal. And more importantly, when the sugar comes down to less than 250, please change to a dextrose containing fluids, and that will help you in this thing. And the sugar should not come down to more than 100 ml, 100 milligram per hour. So DKA and this are very, very simple, straightforward cases. The main people, like the way you're getting stuck, is interpreting the ABG, interpreting osmolar gap, and the questions will go on that rather than this thing. That's all I have to say, ma'am. If you have to ask anything else, please. Otherwise, it's an easy way to pass an exam is to get DKA.
Yeah, in both cases, the dictum is start off with fluids, as DKA is an acid-base crisis, and hyperosmolar hyperglycemic state is a dehydration crisis and osmolarity crisis. So that is what that is where your cutoffs are also to stop insulin and go on overlap sub-Q insulin, and your endpoint in DKA and your endpoint in uh, hyperglycemic state is going to matter. So here, the typical patient population in hyperosmolar or hyperglycemic state is going to be an elderly population with multiple comorbidities. As we saw in the history with DKA, there were no comorbidities except for a high glucose state, which was diagnosed a bit previously. But here, patient may come with a cardiac compromise, a cardiac dysfunction, and then renal dysfunction. So all these also we need to take into account when we are doing electrolyte corrections and fluid corrections, and very frequent assessment is required in these patients on the speed of fluids. Yeah. And what would be your target osmolality?
Ma'am, the target osmolarity, according to the ma'am, it should be below 315, ma'am, milliosmoles.
Okay, less than 320 should be okay. And meanwhile, we need to be also looking for the inciting factor, whatever might have started off this course of events,
Precipitating
and
factor. Yes,
and correct it. Yeah. So
yes, ma'am.
I don't know if we overshot time. So
Yeah, Kalala, you want to add any final marks?
I said overall, I think it's well said. Going like most of the times, the students they don't concentrate on the simple thing what Suresh Ramasubban sir was telling initially. Like DKA means it is all acidosis and all. That's it. APG interpretation, because initially Kavya was a bit not able to properly interpret the ABG. That is very, very important. Even though it is a straightforward DKA, which means acidosis, there is definitely proper interpretation which led to normal iron gap acidosis has come. So those things should not be missed, which can be considered as basic, as sir was telling, because especially in the exams, the examiners will definitely get furious looking at not able to interpret the ABG. That is one thing. Other than that, I think probably they did well. That's what I feel. I think most of the times it's very straightforward because all the guidelines are there, and that's it, sir. Yeah, thank you. Thank you for the opportunity, sir. Yes.
We don't have much questions in the chat box. There are a couple of questions, how to switch to subcutaneous insulin, which has been answered, and also how to calculate expected deficit of fluid, which has also been answered. So there was no much questions this time, and I encourage whoever is participating to ask more questions next time onwards. With this, I think we have come to the end of the session. I thank Dr. Ram Subban sir and Kalavati ma'am for being examiners for today ICU Clinic Diabetic Emergencies. Your insights and valuable feedback contributed greatly to the learning experience. And I also thank Dr. Kaladar for mentoring the students and for constant guidance during the preparation of the case presentation. And I thank Dr. Devaki Kavyasri and Dr. Vishwavati Chakrabarti for their effort and time in case presentation. And I also thank everyone who has joined the Zoom meet. And we need more encouragement next time with more questions. And I also thank ISCCM for the ICU clinic program, which is useful to many critical care trainees and practicing consultants. Thank you very much. We will close this session.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, sir.
Thank you.